Hello, everybody. It's my pleasure to present the first day of European Atherosclerosis Society Congress. We will talk about rivonoflast, a new one for the modulation of inflammation, olezarsen for acute pancreatitis risk reduction, bempedoic acid in real-world data with Miller study, the role of remnant particles, and also the growing role and deleterious role of MASLD and cardiovascular risk. So rivonoflast is a new treatment, an oral inhibitor of inflammation. The presentation was made by Koshray. Koshray was the past president of European Atherosclerosis Society. And the action of rivonoflast, we need to know this treatment, is to target the innate immunity cascade and to decrease chronic inflammation by acting on IL-6. You know that IL-6 is deleterious, whereas CRP is a marker but not a factor of atherosclerosis. IL-6 is a factor of atherosclerosis, is deleterious directly for atherosclerosis, for endothelium, and promotes atherosclerosis complications. So rivonoflast efficacy and safety was assessed in 63 cardiometabolic patients with high risk of cardiovascular events. So they should have a BMI above 30. They should have a high sensitivity CRP as a marker of inflammation and other risk factors. So Koshray and colleagues compared rivonoflast with placebo. It's just the first phase to see the efficacy and safety concerning biomarkers. And you may see that the primary endpoint was high sensitivity CRP. The secondary endpoints were high sensitivity CRP ratio from baseline to final follow-up. The absolute change in IL-6, in my view, is crucial because IL-6 is deleterious, and other biomarkers. What we see with rivonoflast is the first phase demonstrated early and pronounced, sustained, and reversible high sensitivity CRP. So you have a major risk reduction of inflammation. And the most crucial point, and that you have on an individual point of view, a significant decrease of high sensitivity CRP. But the most important in my view, and you have also a decrease of IL-6, because IL-6 is directly deleterious for the arteries wall. So it's a promising first study, and we will have in the next years other study evaluating the clinical efficacy of this promising treatment to modulate not only CRP, which is a marker but not a factor, but also IL-6, which is a factor of atherosclerosis. The second major study was olezarsen. Olezarsen is not really for us cardiologists, but it's for patients. It's crucial because you know that when you have high triglyceride, you don't have a higher risk of cardiovascular events, except if you have triglyceride-rich lipoprotein, but you have a high risk of acute pancreatitis. So acute pancreatitis is associated with a poor prognosis. So you have this molecule, these new molecules, a 19-sense oligonucleotide that targets ApoC3 and decrease triglyceride by more than 50% until 70% from baseline. You see in these studies, you have two studies evaluating olezarsen. You see with these two studies that olezarsen is remarkable efficient by decreasing triglyceride from baseline by more than 70% from baseline, and the effects are persistent over time, and it decreases the risk of acute pancreatitis. You may see that it's very impressive. You just need to treat 9 patients with high triglyceride to prevent one major event, acute pancreatitis. So for patients with high triglycerides, this treatment is very promising. And even if you don't have benefits in cardiovascular events, you decrease a major event, which is acute pancreatitis. So according to patient's profile, patients with high triglyceride may benefit from a treatment by olezarsen. You have also data from real life. You know that bempedoic acid is a new entry in lipid-lowering treatment. Bempedoic acid acts by inhibiting in the same pathway that statins, but is not expressed in the muscle. So bempedoic acid is especially interesting for patients with statins intolerance in combination with ezetimibe, because bempedoic acid without statin decreased by 20% LDL cholesterol from baseline. Associated in fixed combination with ezetimibe, it decreased LDL cholesterol around 40% from baseline. So it's a very effective combination, bempedoic acid, ezetimibe, and it's useful for real intolerant patients to statins, because you know that low dose of potent statins such as rosuvastatin 5 mg or 10 mg are well tolerated. You may have bempedoic acid with these potent statins because it decreased by 15% in this case LDL cholesterol from baseline in association with rosuvastatin. But you know, it's very useful to have confirmation in real life that bempedoic acid is effective and well tolerated. So these are real life data. You know that bempedoic acid was already evaluated in clear outcomes. In clear outcomes, you decrease by 20% LDL cholesterol from baseline in patients with statin intolerance, and you decrease major cardiovascular events during a 3 years follow-up. So in the Miller study is to confirm the efficacy, is biological efficacy of bempedoic acid without background therapy, with ezetimibe and with ezetimibe and statins. And you see that you obtain the same results, that you decrease LDL cholesterol from baseline by more than 20%, and you have a good interaction with ezetimibe. And if you use statins, you have less efficacy because they act on the same pathway. Because you know that bempedoic acid act on the same pathway than statins. So when you have both together, you have further decrease of LDL cholesterol, but you are more effective when you have bempedoic acid with ezetimibe without statin. But statin remains the first-line treatment due to the high amount of proof. So Miller study, you see after 1 year, there's that just confirmed that we see in the clear program and clear outcomes that you obtain LDL decrease as expected with ezetimibe or with moderate or high-intensity statins. But the most indication remains, the first indication remains patients with statins intolerance and in association with ezetimibe. But remember that potent statins remain the first-line treatment, and you have ezetimibe and bempedoic acid if needed. Another issue during this Congress was the remnant cholesterol, and you have a very interesting presentation during the European Atherosclerosis Society Congress and a simultaneous publication in atherosclerosis highlighting the mechanism of remnant cholesterol metabolism and the role in inflammation. So remnant cholesterol, you know that it's a causal modifiable driver of risk. And in this study, we see that ApoC3 inhibition may reduce remnant cholesterol because you have no effective treatment of remnant cholesterol. Statins doesn't act on remnant cholesterol. Ezetimibe doesn't act on remnant cholesterol. It's VLDL. And so if you have this ApoC3 inhibitor, after ApoC3 inhibitor, you may decrease the remnant cholesterol. But don't forget the basics to decrease ApoB and LDL cholesterol using high-intensity statins such as rosuvastatin or atorvastatin, rosuvastatin being the most potent statin at low dose, it's well tolerated, and you may associate this with ezetimibe and or bempedoic acid as previously seen. There's a new era on atherosclerosis session presented during the Congress. It's just to see the drivers of atherosclerosis progression and how to slow the atherosclerosis progression. And you see that the emerging treatment beyond statins and other lipid-lowering treatments are anti-inflammatory therapy. So we have a main interest about modulation on inflammation. We see first results in the previous studies, but you have ongoing studies evaluating how to decrease chronic inflammation in the arterial wall in order to decrease also atherosclerosis progression. So it's a fascinating period. Would you have lipid-lowering treatment, many lipid-lowering treatments, and you have also emerging anti-inflammatory targets very specified to decrease the atherosclerosis progression. So read the article, then you have a session during this European Atherosclerosis Society Congress. So it's a very exciting period because you modulate several targets and specified according to patient's profile. If patients have a residual risk of inflammation, you may modulate this inflammation by specific inhibitors. And the last topic, very crucial also due to the increase of obesity and overweight, is the muscle D and the risk associated with muscle D. And you have a specific session during this Congress, and you have a lot of people who are interested because muscle D is not only accumulation of fat in the liver metabolism, but it's also associated to atherosclerosis, chronic inflammation, cardio-kidney disease. So it's crucial for all healthcare professionals, not only cardiologists, or not only specialists of liver, such as hepatologists, but it's for everyone to be aware that the higher is the degree of muscle D. You have several degrees of muscle D, several degrees of severity, and you have parallel curve between the progression of muscle D and the liver disease, and also the progression of cardiovascular risk. So thank you for your attention, and see you on day 3 after this day 3 highlights, and see you on ESC Congress. Thank you.